Good afternoon, everyone. I think this morning we have a great talk for Professor Fantovich about the limits of science and what can be done respect to giving scientific evidence to decision makings. So I think this afternoon we're going to go deeper into the subject, thinking precisely on what happens when there is a public health emergency, a disease that is racing, and the decisions are to be made. We have a wide panel of experts from both from healthcare, public health policy, decision making, that will talk about the difficulties of taking urgent decisions that should be based on science. And on the other hand, we will explore the pressure on the scientific side also, what they have to do and what are the needs during these situations. So I hope you think that it will be interesting, and we will try to generate a wide debate within the audience. And I let my co-chair, Bruno, to present our panel. Thank you.
Thank you, Jacobo, and I'm very delighted to chair this session and to introduce our speakers. We are really privileged of having colleagues with first-hand experience on the very issue we are addressing today, starting from Professor Alenka Markotic. Professor Markotic is really a unique example of an expert who works for the patients in a clinical setting, still leading large research projects, building infrastructures for research, and advising policymaking at national level, but also at the highest European level, like she did during the pandemic. Then we have the privilege actually of having a representative from the political side, the Deputy Minister of Health of Greece, Ms. Irini Agapidaki. I had the privilege of meeting her during a visit in Greece, and although she joined politics recently, she immediately took a big role in trying to use evidence to inform strengthening the healthcare system in Greece, transforming the surveillance systems, and addressing the most biggest issues, including antimicrobial resistance. Then we have Karin Nygård. She's one of us. She started her APIET training a long time ago, but she made it to the highest level. And in Norway, she's informing decision-making for the government, but also she's very active in strengthening preparedness. And she has managed in a way, together with the team in Norway, to have the population on their sides, because in Norway the population still has a high trust in public institutions. And last but not least, we have the privilege of having with us also Dr. Tanja Kuchenmüller from WHO. And her role here is very important. She has been working a lot in strengthening the methodologies for evidence-based policymaking, but also taking a strong role in building capacity. And we should really not forget that decision-making will ultimately happen at the local level, actually sometimes at individual level. So every investment in building capacity will really pay off at all levels. So this is extremely important. So with that, I think we can actually start. Jacopo, please.
Yeah, just a quick reminder, you can make the questions on the app or just raise your hand. And then the general session, each speaker will have 5 minutes to just introduce the issue from their point of view. Then we will make some questions from the chair, and then we will open the debate to everyone. So we can start with our first, Chair.
Yes, it is a great pleasure to invite Deputy Minister of Health of Greece, Dr. Irini. Please, the floor is yours. You can start with your presentation. Thank you.
Thank you so much. Thank you for the opportunity to join remotely. It was not feasible to be with you today, but even this way, we will have the opportunity to interact and discuss such an important issue. So, ladies and gentlemen, dear colleagues and partners in public health, I would like to make a brief introduction as a political actor, but also as someone that has also the role of a public health expert before jumping to politics. It is precisely this intersection of roles that has grounded my belief that policy must be guided by evidence, especially in times of crisis. So we need to focus on evidence-based pandemic management and try to draw some conclusions and lessons learned to proceed forward and see how we can shape policies for the present and the future. So during the COVID-19 pandemic, Greece made a strategic, and I would say deliberate choice to place scientific evidence at the center of every decision. Our national response was built on data-driven management, guided by recommendations of the National Committee of Experts for the Management of the Pandemic and supported by continuous epidemiological analysis. We understood early that public health trust in institutions and scientific authorities is one of the strongest predictors of engagement with public health measures, a finding consistently confirmed by the international evidence. Research shows that trust in scientists, public health agencies, and medical experts is directly associated with higher acceptance of vaccination and adherence to protective behaviors, whereas distrust and populist-aligned attitudes significantly undermine the uptake of essential interventions. Against this backdrop, Greece prioritized transparent communication and timely evidence-based guidance. Vaccination, as you know, became the cornerstone of our national strategy. To ensure equitable access, we complemented the national vaccination program with the deployment of mobile health units, enabling us to reach people in isolated or underserved areas. For example, serving older adults, people with disabilities, and communities living far from the healthcare facilities. What the pandemic taught us is the simple but decisive: science saves lives, but only when it is trusted and only when it is reached people where they are. Our commitment throughout was to safeguard that trust, uphold scientific integrity, and ensure that reliable information and essential services were accessible to every citizen. In a different case that has to do with a natural disaster, the case of Thessaly, our commitment to evidence-based public health was again tested when Greece was faced severe natural disasters, like was the case of Elias flood or the catastrophic Daniel flood in Thessaly. The Ministry of Health immediately activated a coordinated emergency response. The Regional Public Health Laboratory of Thessaly University was designated as the central coordination hub, and through it, a rigorous plan was implemented: extensive water quality monitoring, enhanced vector surveillance, also epidemiological surveillance. We had to observe, we have to follow up day by day every single data that was available to make sure that we will protect the population from vector-borne diseases. We also implemented house-to-house communication with the mobile units, again, provide protective equipment, informational leaflets, guidance on hygiene, water safety, and disease prevention. We also had to carry out targeted vaccination in high-risk groups, including more than 2,500 tetanus vaccination, for example, for at-risk populations. These interventions were not improvised. They were guided by the national standards, real-time data, and close collaboration with local authorities and scientific institutions. Crises like this show that public health leadership is not measured by certainty, but by the ability to make timely, proportionate decisions while evidence is still emerging. This is how we managed to mitigate the risk for leptospirosis, for example, in the case of Thessaly, and try to eliminate the spread and save hundreds of lives. Apart from that, we proceed very quickly in terms of the progress being made all those years, because in Greece there was a big gap in terms of prevention for non-communicable diseases. So we acted decisively with the PREVENT program, population screening program, offering free tests for breast cancer, colorectal cancer, cervical cancer, as well as cardiovascular disease. And so far, we have more than 4.4 million people out of 6 million people that had already taken their health checkups. Apart from that, we have activated recently a new national policy, mobile health units. Mobile health units provide primary health care to remote areas, even at-home medical care for people that are of older age or with disabilities, and they cannot actually be transferred to a primary healthcare service. So far, the results are promising, but I would like to make good use of the time provided initially now for this introduction, for the introductory remarks, and try to highlight a little bit what is at stake right now. I would say that the era that we've been living is the evidence versus populism, a deliberate choice that we all should make. So allow me to touch briefly on this challenge that affects all of us in public health. The growing influence of populist-aligned beliefs. According to research evidence, such attitudes marked by distrust in institutions, science, and perceived elites consistently reduce the uptake of interventions like vaccination, reproductive health services, and preventive screenings. This is not a theoretical risk. It has real consequences for population health. In Greece, we made a conscious and sometimes politically costly choice to prioritize scientific evidence over populist narratives, even when misinformation was louder and sometimes more appealing. Maintaining this stance requires transparency and clear communication, acknowledging uncertainty while acting decisively. We adhere to 6 key principles of crisis and emergency risk communications. We try to be first, right, credible, to express empathy, promote action, and show respect. Science-based leadership is not about knowing everything. It is about trusting data, trusting institutions, and ensuring that public can trust us in return. Finally, we should not forget that risk perception is always shaped by both the hazard, the objective scientific assessment of the danger, and also the outrage or emotional response that provokes. It's also important to understand that even small hazards can provoke significant public concern if they generate strong outrage. Ladies and gentlemen, public health leadership today requires navigating uncertainty, urgency, and competitive pressures. But our North Star remains constant, scientific evidence paired with human-centered governance. Whether facing a pandemic, a natural disaster, or the silent epidemics of chronic diseases and childhood obesity, our duty is to translate knowledge into action, equitable, transparently, and effectively. Thank you for your attention, and I will be back with more information at the part of questions. Thank you.
Thank you very much, Minister, for your intervention. I think that the situation meets the case definition of complexity that Professor Funtovic described this morning.
Okay, so now we go to our next speaker, Karin Milla, please.
Thank you, and thank you for the invitation to participate in this session. This is really an important topic that has already been discussed this morning and also now presented by the previous speaker. I will present some experience from the Public Health Institute perspective as a scientific advisor during a crisis, and how what we have learned from the pandemic and how we work now to improve our ability to make scientific advice in the next crisis. Just to start with what our mission is, the public health institutes have different missions. In Norway, our mission is to produce, summarize, and communicate knowledge to contribute to good public health and guide health and care services. So it's a quite broad mandate, both in general public health, in communicable diseases, and in terms of healthcare services. The core task is really to produce knowledge and summarize knowledge, more, better, and faster knowledge for health and sustainable services. But we also have a responsibility for preparedness, that we are prepared to provide data-driven and evidence-based advice in crisis. And then we have responsibility to maintain the infrastructure needed, the health registries in Norway, the health data that we need in a crisis, laboratories and services. So it's a general and broad mandate. There's many lessons from the COVID-19 pandemic. I have been working at the Institute for many years and covering many crises, both the big global crises like SARS, MERS and Zika, and also local outbreaks in the municipalities and national outbreaks. But I think what we learned from the COVID-19 pandemic was very special. I think the really urgent need for rapid and accessible evidence for crisis management was immense and enormous, and there were several science gaps that complicated our ability to give science-based advice. There were many uncertainties about the virus and transmission, about the severity, also about the healthcare capacity to manage the situation. And also about the effect of measures and the negative consequences of public health and social measures. And then again, when the vaccine arrived, about the effect and negative consequences of vaccination. So a huge need to produce reliable evidence for these issues. And we realized that we had surveillance data, we had register, but we needed more real-time data from primary healthcare, from contact tracing, and from hospitals and other sources that we need to build the infrastructure and to collect and analyze. And added to that, there was a huge information overload. There were very many pre-published scientific publications and also many reports that were used in crisis management. A lot of this were not peer-reviewed, so we had to assess the quality, and then we had to summarize all the information into evidence-based advice. And added to this, and of course this builds up to that a pandemic is a misinformation and disinformation hotspot. Using social media to disseminate information from pre-published studies that may be inaccurate and may not be of good quality. And the uncertainty and the fright, the insecurity in the population really makes the situation challenging in terms of communication and overcoming this challenge. So what did we learn? I think after the pandemic, there have been many evaluations on what went well, what was challenging, and how can we improve. And several governmental white papers have been published on preparedness in general, on health preparedness, and also on knowledge, better knowledge in an unsecure situation. And they have talked about knowledge preparedness. How do we prepare better to rapidly upscale reliable evidence and data in a crisis? And how can the ministries rapidly achieve this reliable knowledge to support their decision in future crises? This has been a focus in several cross-sectoral white papers as well. We have a revised National Health Preparedness Plan, with now including a separate chapter on knowledge preparedness, which is really a new thing that was not in our previous preparedness plans. And it emphasizes the responsibilities both at the ministry to ensure that we have the right legal framework, that we have the resources and the institutions we need to produce knowledge in a crisis, but also the responsibility as the institutes that are responsible for giving scientific advice, and also of the research sector. What should the academia, what are expected from the academic institutions and the universities in a crisis? It emphasizes that knowledge preparedness requires coordinated efforts across ministries, institutions, and the research sector in order to be able to upscale knowledge production in a crisis. And it also emphasizes the need for scalable infrastructure and collaboration mechanism to produce timely and reliable knowledge. So what are we doing from the Public Health Institutes? We have focused on operationalizing knowledge preparedness. When we are working on our register and surveillance system, we are always thinking they need to be robust and flexible in order to upscale for and adaptable for needs in a crisis. We are emphasizing both national and international collaboration in producing knowledge and evidence. We have included knowledge preparedness in our agreements with the universities. We have established a national pandemic research network that is also working in normal times, because we think we need to use the systems we have in normal times also in a crisis situation. That is more effective. And we also have focused to participate in EU and global networks and projects for research, like the EU Be Ready project, and also the WHO's work on evaluating public health and social measures, that we have established a WHO collaborating center in Norway. The second thing is the legal framework for preparedness register and research. We realized that there were legal limitations in producing knowledge during the pandemic, and now there are several changes in the legal framework to facilitate rapid research in crisis, and also to better use available data and link them in a crisis. At the same time as ethical standards and privacy is accounted for, so that it should not be uncompromising on that. We are working to have pre-approved research protocols to be faster to start research in a crisis. And we also have several internal preparedness plans for upscaling capacity, for surveillance, for laboratory capacity, and also for systematic reviews and research, and how we can use resources outside our institute, like in universities. And a key point that I see also have been addressed previously in some of the posters, we think joint workshops and exercising focusing on knowledge production and decision-making in crisis is crucial, where we work together with the academia, with the scientific advisors, and also decision makers, in order to understand what are the possibilities, what are the limitations, and what are our responsibilities, and what other considerations do we need to take. I think this exercising and knowing each other makes the collaboration in a crisis situation much easier. And as you mentioned in the introduction, Bruno, trust as a foundation for crisis management, this was really highlighted in Norway. Every evaluation has said that the trust in the population was really crucial for the management of the pandemic in Norway. We work together to manage in the crisis response. And the key issue for us is that the trust needs to be built between the crises. It's very difficult to build up trust in the population in a crisis. So this needs to be built between crises and then maintained during a crisis. And as was mentioned in the introduction and also in other presentations, Communication needs to be timely, transparent, engaging, proactive, but also reactive. You need to listen to the concerns in the population and react to that and explain if there are something that they don't understand or that they need more information about. So the social media listening is important, and also the direct dialogue with interest groups in the population. And this trust really builds resilience for mis and disinformation in a crisis. If they have trust in the institution, they're more robust for this disinformation. The evaluation committee in Norway commented that communication strategies in future crises should be based on the principle of transparency as a trust-building factor. Really transparency about how the decisions are made, what is the rationale behind the decisions, what is the scientific evidence, and what are the other considerations that the politicians need to take when they make decisions. They may be societal factors, there may be other interests outside the scientific evidence that will impact the decision, but that needs to be transparent. That was the last. I will end with a quote from the Deputy Minister of Health in Norway at the regional IAMFI meeting in Oslo 1 month ago. I think it really summarizes the importance of the independence of us as a scientific institution. In today's climate of misinformation and fiscal pressure, science-based guidance from independent public health institutes is more important than ever. And adherence to the highest ethical standards and scientific independence is fundamental to public trust. I think this is important to consider in the current situation. Thank you.
Thank you very much, Karin, for showing us a specific product that can help the decision maker to take the good decisions.
Okay, it's now my pleasure to invite Dr. Tanja Huckenmüller from WHO to give her introductory speech.
Thank you so much, Bruno, for the introduction, and to ECDC for the invitation for me to join this panel today. It's always inspiring to listen to the experience of the co-panelists and really getting to know their fantastic work. So my name is Tanja Huckenmüller. I lead WHO's Evidence to Policy and Impact portfolio, including EVIPNet, one of our flagship initiatives of evidence-informed policymaking. This work sits in the Research and Ethics Ecosystem Strengthening Unit, which I coordinate and which is part of the Department of Science for Health at WHO. Before actually starting with my presentation, let me begin with what I would call a simple truth, one we all recognize, but too often remember only in hindsight, and that is when crises strike, it's far too late to start building trust. In moments of upheaval, a pandemic, as we heard, or natural disaster, which we also heard about, a geopolitical shock, in that moment, decision makers simply do not have the luxury or time. They have to act swiftly, confidently, and transparently, and people have to trust that those decisions are grounded in the best available evidence, not in speculation, politics, or pressure. And this is precisely where EVIPNet, the WHO Evidence-Informed Policy Network, plays a critical role, because the evidence systems we build in times of stability, and as Karin was saying, it's very important to also make use of times of stability, are the very systems that save lives in times of crisis. So if I could get to the next slide. So let me explain a little what EVIPNet is and does. EVIPNet is at its core a global WHO initiative, one that has been steadily expanding for nearly 2 decades now, with the support and in close collaboration with WHO partners, collaborating centers. And its mission is to enable countries to not just produce, but actually use evidence to inform decisions. We do this by promoting cutting-edge approaches to knowledge translation, approaches that recognize complexity, draw from the best international methodologies, and respond to real-world policy needs. These means bringing global evidence together with local realities and helping countries use existing synthesis, so systematic reviews, living evidence maps, and other products before commissioning new research. This saves time, avoids duplication, and ensures resources are used to inform policy more effectively. Today, EVIPNet supports evidence interaction efforts in more than 50 countries. And unfortunately, this is not just about access to evidence. It's really about strengthening the systems, processes, and capacities that make evidence use routine, not reactive and not ad hoc, and not only in moments of crisis, because again, the systems we build in times of stability are, as I just mentioned, the very systems that save lives when emergencies hit too. And to do this, EVIPNet offers a suite of tools, capacity building opportunities, and networks that help countries institutionalize evidence use within everyday governance. Just as critically, EVIPNet acts as a bridge across the evidence ecosystem, connecting policymakers, researchers, civil society, and development partners. These relationships then foster trust, collaboration, and the in-kind experience, the dialogue that promote evidence-informed decision-making. So really the linkages between evidence and policy both need to be possible, but also sustainable. So to reiterate, because trust capacities and partnerships cannot be built in the middle of a crisis, they are built through steady collaboration and institutionalization over time. And this is what EVIPNet is designated to enable. Let's move to the next slide. So moving on now from initiatives like EVIPNet that are aiming to support and promote the systematic and transparent use of evidence amid the pressures of day-to-day policymaking, not only in crisis. Let's move to the question of what we actually know about what works in the field of knowledge translation. A couple of years back, we commissioned to the Pan-Africa Collective for Evidence the development of a living evidence gap map on the science and art of using evidence, which provides a critical overview of the existing evidence in this field. And this map shows that the global community overall has made real progress. We now see a growing maturity in the field, a wider use of knowledge on rapid synthesis, more demand-driven approaches, stronger brokering models, and also an increasing recognition that evidence use is both technical and relational endeavor. Yet, importantly, there are gaps that remain. For example, impact assessment, but also the situations where decisions must be made quickly under uncertainty and political pressures. In those moments, evidence competes, as we know, with urgency, with emotion and vested interest. And the challenge is not just to produce evidence, it's to rather protect its use and ensure that credible information rises above the noise of misinformation. And this area is where still quite a bit of collective learning needs to happen. We still know too little about how evidence to policy mechanisms function in crisis, how institutional trust, leadership, and system design the evidence use when, in fact, it matters most. Next slide, please. So at WHO, we are now taking these insights forward through the Global Research Agenda on Knowledge Translation and Evidence-Informed Policymaking, which was just launched earlier this year. It's a collective framework designed to identify and address the most pressing gaps in how evidence is generated, translated, and used. The agenda spans 19 domains, from institutionalization and context adaptation to digital innovation and capacity strengthening. The infographic that you see on this slide, and really my apologies for it being so small, but it captures the full scope of the agenda, its development process on the left side, and its priorities and domains that now guide our global efforts on the right-hand side. Among these domains, one of the critical gaps is understanding and testing strategies for translating evidence in times of crisis. When uncertainty is high and decisions must be made fast, I've highlighted this research domain with a black box on the right side for ease of reference. So in other words, despite the progress we have made in evidence to policy, there's still much to learn and much to test, much to also uncover about how we can ensure that evidence truly informs action, especially when pressure is the greatest. And what we're doing now is collectively we are advancing the implementation of this global research agenda, helping or trying to help ensure that research efforts in this field are driven by the priorities that we had identified, that they're aligned also across sectors. It's not just a health-related global research agenda, it really is multi-sectoral in nature. And also that these activities are coordinated in a way to minimize duplication and increase overall impact of the research work. Next slide. So while there is, as I've highlighted, still much to learn, which interventions, for example, which tools and approaches might work best specifically in emergencies, one thing feels fairly clear to me, that is that evidence ecosystems are like the social fabric of health governance. They must be woven in times of peace if they're told to be firm in times of crisis. And this is exactly what the Evidence-Informed Policy Network seeks to nurture by helping countries and supporting them, weaving these ecosystems that are grounded in trust, transparency, and collaboration. So with that, EVIPNet tries to enable to develop the resilience needed to act swiftly and credibly, both in routine policymaking and in moments of intense pressures, such as in crisis. So let me stop here and thank you for your attention.
Okay, thank you very much, Tanya, and also for staying within the time. We can then move on to it.
Yes, last but not least, our live speaker, Professor Alenka Markovic. The stage is yours.
Thank you. Good afternoon, dear colleagues. It's my real honor to be here in this very special and very interesting plenary session. And as you could see, my background and my whole career is linked to different epidemics, and unfortunately at the end, pandemic started with the hantaviruses and several different outbreaks, and now with pandemic, but also with some other disasters like war and aggression in 90s on my two homelands, Croatia and Bosnia and Herzegovina, and also during the pandemic we had to face earthquake. But anyway, I will talk today mostly from the clinical perspective and what was happened and what are our experience during the COVID pandemic time. So what was the clinical reality at the first point? That was the first shock when we saw what is going on in China and then also in some European countries. Luckily, Croatia had some time to be prepared, and due to high level of public trust and possibility to have some time to train the people and to establish some initial diagnostic facility, we more or less passed first wave smoothly, but then real shock came with the second wave when we lose a lot of trust and people were tired from many rules and lockdown and everything. So anyway, in the first wave and especially in the second wave, but till the end of the pandemic, we faced sudden surge in morbidity and mortality, and it was really difficult to deal with that because complete infectious diseases departments, but also other departments which were transformed to COVID units were overwhelmed, and especially it was pretty difficult to deal with intensive care units overload within days. And I remember that for many nights I spoke with my colleagues, directors of different institutions, talking about the number of beds which we have till the morning with the ventilators and all that necessary stuff. And we all were in the middle of uncertainty when the public really expected from us to be absolutely certain what we are talking, what we are doing, and it was really a huge challenge to deal with that. from the clinical perspective, what we faced from the very beginning is that we needed to reorganize the hospitals overnight. And as you could see, some of the facility looks more than war hospitals than normal hospitals. We even started to build modular isolation units, make improvisation tents and containers before it to be able to treat all the patients which appeared during a day and during a month and years. So what we faced at the very beginning is lack of beds and ventilators and shortage of oxygen, and we needed to take care about all of this. But also the huge challenge was to get PPE. It was the shortage of it. I remember that it was one of my most difficult days when I was aware that we have PPE only for 2 days, and I was completely uncertain that the supply will be on time. Luckily, we got it on time. Then we faced a lot of problems with infectious diseases, waste disposal, transportation, containers, and it was a big issue as well. And it was all also connected with the problems with the procurement. If you deal with that, then you are aware of what I'm talking about, because you have to obey the rules. It is slow process, and you need everything immediately, even yesterday. So we had to adapt some also laws and rules to be able to supply all the clinical but also public health institutions properly and on time. What was also the bottleneck, it was diagnostic bottleneck from the very beginning. First, we didn't have, most of the diagnostic tools were in-house diagnostic tools at the very beginning of the pandemic. But also later on, when some commercial diagnostics appeared, there was a lack of machines, lack of reagents, lack of everything. So we actually take advantage of it, and really in Croatia and in many other countries, I believe, build a much stronger diagnostic infrastructure than we had it before the pandemic. Also, there was workforce shortage, burnout, quarantines, and what we know is that workforce, the healthcare workers are the heart and the brain of all health systems, and especially they're important during the pandemics, but they're also probably the weakest part of the system. Just give me to take a short break and to emphasize that actually we in Croatia has historical huge experience in quarantine, because Dubrovnik city in Croatia established the first quarantine in the world in 14th century on July 27 in 1377, and we got several years ago credits for it from the Journal of Emerging Infectious Diseases by American CDC. So how it is coordinated under the pressure, I can say that we had extremely good collaboration with inter-hospitals. We exchanged all what we could, equipment, reagents, supplies, even personnel, and it works well, but it was again shortage of the people and shortage of the everything. We had to communicate with the Ministry of Health and the media on a daily basis, even several times, dealing with the new facts and we certainly put all the efforts toward with the science to the new clinical pathways, and there was good action from the European EU Commission, who actually established a small expert group, and I was honored to be a part of that group, who had task to decide in a short period of time, taking in account all drugs which could be useful for the treatment of COVID-19, and in a short period of time we actually recommended the 10 most promising treatment for COVID-19. We followed different variants and clinical response with that variants and many other things. And at the very beginning, I mean, very fast after the COVID-19 appeared, we faced that it is not only acute disease, but that it is also a disease with chronic consequences, serious chronic consequences, and almost 1,000 different phases in clinical outputs. And that the things will be more complicated. We found out, of course, as with many other infectious diseases, that chronic diseases and national habits may have influenced morbidity and mortality very strongly, especially if you have nations which enjoy in different very good meals and then gain the weight and all other chronic diseases linked to that. So what was also the challenge at the clinical but all other levels is national decision making, taking in account science and external pressures. We had to bring daily decisions with incomplete data, so you need some courage to do that. You need the courage to say sometimes I don't know the answer on that question, but I'll do my best to find it. And of course, one of the hardest things for the medical professional was to deal with misinformation. Even some colleagues, scientists, narcissoid colleagues who didn't get enough attention took that side, and then we had to deal with anti-vax movement. And unfortunately, with the political actors, and unfortunately in Croatia, we had 3 elections at national and local level. So politicians really selfishly used the situation and place different misinformation to get some votes. So during that time, we had to balance epidemiology, economy, and trust, and we had to, as a medical professional, learn that it is not everything on the medical side. So when we had a strong discussion with our Prime Minister and asked that he prolong strong lockdown for more days and more weeks, he said, okay, I understand you, but what will the nation eat if we put whole economy on standby? So we had to make a balance of everything in real life. But don't think that it is something which is, especially for this age or for this situation, almost similar things appeared. If you read a science paper from 1990 during the Spanish flu, they deal with the same problems, almost the same problems 100 years ago with the people, with the with the science and with the all problems which I already mentioned. And at the end, what I would like to send a message is that it is important to be transparent, to be really brave, to build a trust, and to decide rapidly, because any delay in decision, even if you're uncertain, could be more with more consequences than if you're giving rapid decisions. We have to know that the workforce is main vulnerability, and that we have to put a lot of efforts in continuous training. We have to have stronger diagnostic and data infrastructure with the help, of course, probably today with AI. And of course, and it is the hard task, to protect public health from political interference and do a training in crisis communication, so that at the end, when we in the future face against some invisible enemy, we don't have tango of death. We can enjoy Vivaldi beautiful music of Tango of Death, but we have to take advantage from the lessons learned and from the future direction. It take some scientific innovative steps and take the leadership in that tango, so that it would be a tango of life and that we beat the beast. Thank you.
Thank you very much.
Okay, we can move now to the second part of this meeting, and we'll try to stick now with the time. So we're a little bit over time. And imagine, and we go in. I will ask a question, and we go in the different order now, starting from the last speaker back to the first one. And I will ask you to please answer in 2 minutes, no more than 2 minutes. We are in a situation of high pressure, and policy makers are asking for your advice, but in a situation of very low, very high uncertainty and lack of peer-reviewed evidence. So what is your approach? I mean, what should the public health people and epidemiologists do? What is their role? And particularly, how public health leadership can perhaps even in those moments prioritize generation of evidence as one of the key decisions that are often not taken when they need to be taken. And the other point is, how do we as community of epidemiologists are able to actually focus on actionable research and when we face important public health problems. So I put it there. We start with Professor Markovic.
Oh, well, it's I spent all my text, I think. Yeah. Well, it's really difficult to deal with all of this, but I think the strong collaboration with different disciplines, with public health, with epidemiologists, clinicians, diagnostics, microbiologists, it is important and it is some cornerstone to be able to face some future pandemics and to take leadership and to see what we can do together. It was also a lesson learned from the COVID-19 when the whole scientific community gathered, and we put a lot of science information in the daily knowledge, and we exchange the knowledge on a daily basis and start to do a good work, taking in account all that networks which we had.
Thank you. Thank you very much. So what do you think, Tanya?
Yeah, I mean, I would add on to what Alemka said, and definitely, I mean, collaboration is key, collaboration and communication on a regular basis to address decision-making in high-pressure scenarios. I would say it's very important, in particular, if one is facing at the same time scientific uncertainty, it's very important to acknowledge the tension so that you are in the pressure situation, and one has two imperatives. It's actively, on the one hand, acting swiftly, and upholding on the other hand, the scientific rigor and transparency. And when evidence is incomplete or rapidly evolving, as we've seen during COVID, then the goal is not to wait for certainty, but to act on the best available evidence, right? So clearly communicating how confident we are in the evidence and the need to assess and communicate the certainty of the evidence. So I think that's really one important point, to acknowledge the tension, but also to draw on multiple sources of evidence with a certain structure and a system, so in a systematic manner. We heard about preprints, real-world surveillance data, expert consensus and modeling. So it's really important to look at the different forms of evidence and to synthesize them in a systematic and transparent way. I think keeping at the same time also the need for decisions to be adaptive in mind. So if there's a lot of uncertainty of the evidence, the decisions need to be labeled as provisional and revisited regularly, so that there is an adaptive and learning-oriented approach that really allows for data to be included whenever it's collected. And then lastly, we have spoken so much also about trust, the need to build trust, the need to sustain trust, and working also through trusted and institutional channels. And I think in such a context, it's highly relevant that we are building on institutions, as we have heard, whether society such as in Norway has a lot of trust in, because trust is in crisis situations the real currency. So I think I would leave it with that.
Thank you. And I will ask now Karin, please.
Yes, thank you. I think actually Tanya went through most of the issues, but as a public health institute, we are supposed to give advice even if the science and evidence are not there. But of course, we use available evidence. We use preprints and we assess the quality and do the systematic reviews and summarize all the information. And what we do in Norway is that we regularly publish national risk assessment, where we summarize all the available evidence, and then we highlight the uncertainties. So it's very clear what we know and what we don't know in the risk assessment, and we also illustrate options that they can take. We acknowledge then in a situation where there are large uncertainties, it's actually, as I think Silvio mentioned this morning, it's a political decision to decide how much risk are you willing to take when the situation is uncertain, and how much precautionary do you need to take, looking at all the other consequences some measures may have in society. So I think also the use of the scenarios, if we don't know the transmission, the severity, we can use scenarios to illustrate for the decision makers what are the possible outcomes of a situation and what are the possible outcomes of different response. If you want to have very strict measures, or if you want to wait and see, there are different outcomes that they need to take into account in their decision making. So thorough risk assessment with different scenarios illustrating uncertainty in the situation and possible option to take would provide the decision makers with a basis to make their decision. And then we know that there are political priorities that needs to be taken into account. On top of that, there are broader societal aspects that they also need to consider. So this is sort of to give them a scientific background for the decision.
Thank you so much.
That was quite short.
And finally, I would like to hear also from Deputy Minister Gapidaki.
Yeah, thank you. I will try to bring together the political, the policy making, and the scientific public health expert points of view. I would say that the most effective approach from where I stand rests on three principles. First of all, transparency about uncertainty. This is so important. It is essential to communicate clearly what we know, what we do not yet know, and what assumptions guide our recommendations. Evidence evolves, especially in the early stages of the crisis, but clarity builds trust even when certainty is not possible. Second, structured, data-driven decision-making. During the pandemic in Greece, we relied consistently on the scientific guidance of expert committees and real-life and real-time epidemiological indicators. This allowed us to adjust measures dynamically as evidence evolved. The goal is not to wait for peer-reviewed publications, but to use the best available data responsibly and rapidly. The Prime Minister's Cabinet, for example, this is an example of how we brought together public health policy and politics, if I may. So we had the central coordination mechanism by the Prime Minister's Cabinet, and especially the Minister Actis Kessers was mainly involved and shaped the framework for pandemic management based on evidence, societal input, digital tools, emerging threats, and equity-focused implementation, which is very important. So interventions must reach people where they are, geographically, socially, and culturally. And mobile health units allowed us to reach every single citizen and be both effective and inclusive. Ultimately, evidence-based leadership under pressure is not about having all the answers. It is about making proportionate, transparent, and timely decisions guided by the strongest evidence available and always anchored in the responsibility to protect public health.
Thank you. Thank you very much. And I thank all the speakers. I mean, you have raised very important points. And the only thing I would add is also the importance of responding to what happens to the event, but then using the opportunity for generating evidence. And this is really the essence of field epidemiology. So this audience here is actually spot on for that. Let's move on. Jacobo.
Thank you. I think I have a very good debate, but we all know that decisions are not made only based on science, especially when there are uncertainties. So there are other factors, social, economical, political factors that also play a very important role. Science is not, maybe for science, yes, but for the rest of the society, just a part of the decision. So the question for all of you is how, as public health officials, we can ensure that policies have informed scientific evidence integrated in all these areas, how they took the scientific evidence and mixed together to take the good decision. And we'll start with you.
Okay, well, as I said, everything should be transparent as much as it's possible. So it is sometimes difficult to speak the same language if you're a scientist with the politicians or economists or social scientists, and we have to find a common language and on a simple way try to explain to each other what is going on and what is important from the medical side, but also listen and learn what is important from other aspects of life, economical, even if you would like to say schools, education, even art, many museums, theaters were closed and shut down. So there are a lot of impacts and issues on everyday's life with that pandemic. And what I learned is that really I have to be clear, I have to insist with the courage and with the evidence-based facts to establish some medical measures, but also I have to understand that I have to adapt it to other aspects of life and well-being.
Thank you very much. Tanya, what are your thoughts on this?
Yeah, so if it's not in a situation where a decision needs to be taken instantly, in a crisis situation, this would be likely more challenging. But otherwise, the EVIPNet teams with which we work, we ask them once a high policy priority has been identified to undertake a political economy analysis surrounding the policy priority to really have an understanding what are the economic, the social and political factors that the policy problem is embedded in. And then again, starting with the best available evidence, while acknowledging and recognizing uncertainties and context. It's relevant here. What we suggest is in an evidence brief for policy that we clearly underline what the problem is. So, for example, the problem framing is really important. What does the audience, who are the target users, what kind of a policy narrative is it important to reach out to them? Demonstrate the scope, the urgency, and also the consequences of inaction. Then highlighting the different policy options, feasible policy options, the expected impact, trade-offs, and also implications for equity, resources, and feasibility. And then apart from options, problem options, also implementation considerations. So how can decision makers not only have a solution at hand to address the problem, but how can they implement the solution in a given context, given the practical requirements, the constraints, etc. So that's one important step. But then in addition, looking at engagement and deliberative processes, so that next to the research evidence, also other factors and rather looking into economic feasibility, equity, social acceptability, and political viability, given a specific context, is more taken into consideration. This deliberative process should be ideally also complemented by early on engaging interest holders, so from other policymakers, communities, economists, etc. If in this context also transparent frameworks can be used, so WHO, we very much use the evidence to decision framework. That also again highlights the credibility of the evidence for decision makers to use next to factors, as you have mentioned earlier, such as economic, social, and political factors, which always will come into play when we think about decision making in the policy context that are taken. So maybe this is just a quick perspective from my side.
Okay, thank you very much. I think, okay, Karin, what are your thoughts on this subject?
Yeah, there are many things at the table that has been presented already, but I think the thing being clearly about the scientific data and evidence that are available, and what we mentioned, what are the uncertainties, are really important. But I also think that in order to provide the policymakers and the decision makers with the right advice, it's really important to know what are their needs and how they work, and what are their consideration and the processes. And this is something that we can work on between the crises. And this is part of what we are doing in the work on knowledge preparedness also, is that we try to make exercises focusing on decision making in a crisis. We already just recently had the exercise or workshop led by ECDC on decision on PHSM in crisis, where both different sectors were present, and also Public Health Institute and the ministry. And then we discussed together, how do we work in a crisis situation to implement this measure? What kind of evidence do we need to collect? What do we have, and what do the decision makers need from us in a crisis? So I think this collaboration in peacetime between scientific institute, academia, and policymakers is really important in order to be able to provide what they need from us in a situation. I also think this using multidisciplinary expert groups, pulling expertise from different disciplines together, sit together and discuss the situation. From the public health, we present the evidence and data we have, and then we have the other perspective in this expert group to provide a more broader picture of the situation, and different options to take in different situations. So I think that are at least some of the discussions we have had here on how we can improve this in a crisis situation.
Thank you very much. Ministry Agapidaki, please, what are your comments?
Very insightful about my remarks by prior speakers. Allow me just to highlight that public health decisions do not happen in a vacuum. They intersect with the economic priorities, social expectations already stressed out, and political realities. The challenge is to ensure that scientific evidence is not diluted by these pressures, but rather integrated intelligently into a broader decision-making framework. To achieve this, we must understand the complementarity between the roles of experts and political actors. Secondly, scientific data must be translated into real-world implications that policymakers can use. For example, our national screening program for the secondary prevention of main chronic diseases demonstrates how evidence on early detection can be operationalized into a system that makes the right choice an easy choice for everyone. And how is this translated into practice? We did not include only the first-line health checkups according to the evidence-based frameworks and the guidelines. For example, for breast cancer screening, the population screening program does not give for free only the mammograms, but the full range of clinical exams, including biopsies. This approach ensures that citizens suffering from social inequalities do not hesitate to have the first-line exam due to the cost, perhaps, even the transportation cost, of further medical checkups. When science is linked to concrete social and economic benefits, from reduced treatment costs to healthier, more productive lives, it becomes an ally rather than a competitor to policy. Third, we must ensure that decisions account for health inequalities. Evidence should illuminate who is most at risk and why. Our prevention initiatives, from universal vaccination access to the National Action Against Childhood Obesity, are built on the principle that equitable health outcomes are not only scientifically sound, but socially and politically essential. Science does not replace broader societal considerations, but it must remain the compass that keeps policy grounded in reality and oriented toward the public good. One last thing, allow me to highlight the fact that we must reconsider what were the lessons learned for the wins and fails from the pandemic, and see how we can bring further, closer public health policy and politics together, because we currently face a new pandemic of fake news, disinformation. This is how we should work together and not try to compete each other. I mean, there is a common route that we can be an ally and proceed forward, rather than try to develop a debate between the policymakers or the political actors and the scientific community. This is something that at the end of the day results to mistrust in the general population.
Thank you so much, and maybe we touch again on the trust of the population. But first, let me take a round of questions from the audience, and I will ask us now to reply with just some of you, not all of you. So one question is for Karin, and it's a very practical question. I think many people, including myself, were quite impressed that you have foreseen in your plans the possibility to really have allocated resources for generating knowledge. And there is a question from the audience says, has funding been allocated for establishing the pandemic research network? And how do you recruit or select research collaborators from academia?
Yes, thank you for that. Very good question. I think during the pandemic, the Research Council in Norway was actually very active in providing funding for research that were relevant for crisis management. So this was a high priority from the government and from the Research Council to have dispersed funding so that all the researchers and all the academia can contribute to produce knowledge in a crisis. However, during the pandemic, it was not organized. It was a bit duplication of efforts, and it was not always the most relevant research that was produced. So after the evaluation, it was seen that we need some more coordinated approach with the scientific institutes and academia to produce the relevant data and knowledge in a crisis. And based on that, they also provided funding to establish this pandemic research network to have a structure in a peacetime or in normal situation which we can use to upscale in a crisis situation. And the network is coordinated by our institute, but it has representatives from the university hospitals, from the university more broadly with different disciplines available, and also other relevant research institutes are included, and they have grouped this network in different topical areas. So it's clinical research, it's research in population and society and public health and social measures, and it's healthcare research. So there are different thematic groups in this network that collaborate in peacetime, also on applying for funding for research project between crises. So they collaborate in different projects in normal time. And we think this collaboration, this established collaboration that we are working to get established now, this will really be a nice structure that we can use in a crisis situation to upscale, because during the pandemic it was mainly our institute that did a lot of work to try to produce the data and knowledge, and there were a lot of research outside the institute that were not linked to the work we are doing. So this is something that we would like to improve now with this pandemic research network, with some funding from the Research Council. Thank you.
Thank you very much, Karin. Now there is a difficult question from one of the colleagues in the audience, which I think maybe only Minister Gapidaki can answer or try to answer. How can we prepare for situations where fostering science-based decision-making is necessary, but decision makers hold views that conflict with the scientific consensus? I mean, of course, this is also linked to the current more kind of geopolitical situation, the trust in scientific bodies, etc., etc. There is no answer to this, but I think it's important to have some reflections at least.
This question. Well, I was serving as a general secretary of public health during the pandemic, and I had to deal with many different groups of scientists of the different scientific fields, the clinicians, the epidemiologists, field epidemiologists, and they had different views. All of them, they were well equipped with data, but you have to combine different elements. You need to be open-minded. You need to communicate clearly and directly with a different group of scientists. And I must say that in most of cases, it was really hard to combine the clinician view and the public health view, bring them together, try to understand that we cannot prioritize, for example, the hospital, let's say, related measures over the public health measures. We need to have a combined approach that can actually address the multi-level framework of needs of the citizens. On the other hand, it's very difficult sometimes to convince scientists that we are on the same side of the table. They feel like they feel suspicious about political actors and politicians. And I was lucky enough because most of them, we've been working together because my prior professional role was on the field of the public health in the academic sector. So it was very helpful, the fact that they knew that they had to deal with someone that has a concrete background on public health. On the other hand, we live in an era that politics are not very relevant, like was the case of the 80s and 90s. We need more experts in the political scene. We need people that can actually understand deeply what data-driven policy making stands for. Otherwise, I don't really think that we will be able to address the multiple challenges nowadays, and the geopolitical, the public health, the global health challenges, the bioclimate circumstances. I mean, it's so challenging to serve as a political actor or policymaker or scientist nowadays with all this mistrust and misinformation. That's why I believe that we must understand that we are all responsible, each and every of us from our side. Our duty has, first of all, to do with the protection of the general population and the most vulnerable groups. So we are allies in that. We need to understand the complementarity. It's more or less how multidisciplinary teams can actually work, not with parallel practice, but with a deep understanding of the role of each and every actor and the contribution to the final outcome. So I would reflect more or less with these words.
Thank you. Thank you so much for that. And I think we all can agree on the importance of focusing on people health as the main priority. And I think if you find a common language between scientists and policymakers, that could really make a difference. I don't believe there could be a policymaker that would say, I don't do this for public health. Okay. But thanks for that contribution. And Jacopo, do you have other questions from the audience?
Yes, I have one for Tanya. I think we spoke a lot about decision maker versus scientifics, to say that way. But we also see during the pandemic that there was I don't know how to call it, a public exercise to participate, to collaborate, and to be involved in the response to the pandemic. So I think how do you think we can involve members of the public, of the general population, maybe, in urgent decisions where there's a lot of uncertainty? How can we democratize this and just, I don't know, make them participate also when the crisis is over us?
Yeah, excellent question. I think frequently when we think about evidence-informed decision-making, we think about the decision makers, the researchers, as you said, sometimes other interest holders, but the general public is often ignored. And maybe if I may, just to get back to the previous question, because we had a very interesting exercise that we undertook. We have a very strong EVIPNet team and EVIPNet platform in the Ministry of Health in Brazil. And as you know, the previous government was also very much dismantling the use of evidence in decision-making processes, including during the crisis. And while in that moment, when there is hesitance and resistance of decision makers to use evidence, there's very little one can actually do. But the beauty is if there is already a certain system in place, a certain culture, then once government changes again, then that can be revitalized. And so what we realized in Brazil was that in the area of health, evidence-informed decision-making was very much institutionalized already. And while dismantling took place during the former government, it did not completely disappear. There was the civil servants who knew the norms and standards in this area. There was a certain, again, culture and demand for it as well. So in that sense, that area of work could continue existing and was revitalized now under the new government, while other areas, for example, in the environment and climate change, there was a commission that didn't survive the dismantling of the former government. So again, to say that if in peace times one develops structures, one develops capacities that can be either mobilized during crisis or even can be resistant and resilient against dismantling and efforts that aim to break the use of evidence, the trust in evidence, the credibility of evidence. Again, just a plea for us to move things forward, believing in if everyone makes an extra effort and moves on the pathway of institutionalizing evidence-informed decision-making, it actually makes a difference, although sometimes we have to go 5 steps back again, but we can move forward again. And Brazil was a very good example for us in this area. Involving citizens more into decision-making processes, we developed tools that allow for citizens engagement, mini publics they're called, so that when certain knowledge.
We lost the sound?
Tanya, 1 second, we lost you. The audio is not working.
Sorry, where did you lose me?
Yes, now we lost just 10 seconds, no more.
So I was saying that it's very relevant that we also look at strengthening mechanisms that actually allow for engaging systematically with the general public. We have tools that allow for policy dialogue. So in this case, specific interest holders group are being invited to deliberate on a particular high priority topic, which was presented to decision makers already in an evidence brief for policy. But in addition to involving interest holders and interest holders group, we also focus specifically on citizens. That means that they are also presented the research evidence in lay, women, men's language, but at the same time they're invited to deliberate the evidence, adding their perspective, adding their own lived experience, which is very important to consider and to give voice in the context of using evidence for policy processes. So maybe that as emphasizing the need for us to involve the public and citizens more systematically in evidence-informed policymaking.
Okay, thank you very much. And I think we have time for one last question for you, Tanya. So talking also about the general public, do you think we're able to communicate them about the uncertainties that are inherent to the scientific knowledge? That we communicate how robust could communicate how robust are the evidence that we have, that they understand how science work or not work, what expectations can they have about the scientific response to questions? What do you think about it?
Well, yeah, I think if I follow what Tanya said, it is very important to hear public voice and to listen it and to try to understand what is problem in their understanding of science. So we need to try to present it on a very simple way, to be consistent and but at the same time explain to the people that dynamic is that the science is dynamic. It is not static, and especially if you're dealing with something new, like in a pandemic with new disease, new pathogen, there are a lot of things which you don't know today, but in a few days, few weeks, few months, you will know more. Maybe sometimes what you said on today will not be completely true in several weeks. So they have to understand that, because it was a lot of argues on the situation when we, for example, said some information which at that time were true and relevant and supposed to be useful, and then after several months of research and new knowledge which was gained, we tried to correct that, to explain to the nation, to the public, that some different approaches we have to take, and then it is problem sometimes for them to understand. So they said, okay, a few months ago you said this and now you are talking about this. So it is important continuously, not to wait that pandemic happened, that new disease X happened, but it is important continuous education of the public. In Croatia started a program from the Society of Biosafety and Biosecurity, established for 5 years now a program in the schools. So the kids are learning about biosafety, biosecurity, preparedness, all that informations and measures. They even are doing, there's some small research, and we have annual competition where they presented their posters, their research, and I mean, talking about their knowledge in that field. So I think it is also important to start from the very beginning with the education of the nation from the childhood. So that is one example. And we translated that to Bosnia and Herzegovina, so they're doing the same now. And I would like also to invite people who are interested to join us in that action. We'll be happy to include you and to do some good and interesting and funny things with the kids as well.
That's a fantastic program. Thank you very much. And thank you very much all for your insights and for your participation in this debate. I think we have no more time.
Thank you also to the fantastic audience. You asked so many good questions, and some we cannot prioritize, but I trust that the speakers have provided also answers to the question that we were not be able to read. And so thanks again to our speakers and guests. It was a very insightful session. Thank you, everyone. Bye for now.
Thank you.